From interviews to jail calls, Ditto Transcripts delivers fast, confidential, and court ready transcription for law enforcement agencies. Ditto is CJIS compliant and is already working with agencies all over the U.S., including the Washington State Patrol and the National Park Service Investigations Unit. Get started now at dittotranscripts.com. That's dittotranscripts.com. To hear details about all the applications of Ditto Transcripts and exactly why this is a key solution for your organization's workload issues, check out episode 232. You train for the threats you can see, but what about the ones you can't? United Diagnostic Services brings hospital-grade diagnostic technology directly to first responder agencies, making early detection of cardiovascular disease and cancer more accessible than ever. UDS provides comprehensive early detection programs using advanced ultrasound, CT calcium scoring, stress echoes, and innovative blood panels to identify potential health risks long before symptoms appear. It's proactive, on-site, and built specifically for those who serve. Early detection saves lives and careers. Learn more at udshealth.com. The views and opinions expressed by the host and guests of this show do not represent their employing agency, department, or organization. All information should be regarded as anecdotal, contextual, and educational, and should not be misinterpreted as legal or medical advice. Welcome to Blue Grit Radio, the podcast that explores making better cops for a better community. I'm your host, Eric Tung. I've been an active police officer since 2007. We will dive into the aspects of police culture, health and wellness, leadership, and mindset. You'll hear from experts not only from policing, but all industries as they relate to being our best with purpose, passion, and positivity. Join me as we share stories, lessons, and advice so we can all be better for ourselves, our teams, our families, and our communities. All right, welcome back, everyone. Today, I'm really excited to feature two doctors. That's not one, but two doctors speaking on a lot of the things we talk about, which is first responder, mental health, that's also interplayed with veteran mental health, because there are different considerations, there are different factors that may affect our communities, but also, as many of us know that are in these types of communities, there's a lot of overlap and a lot of interplay. We have a lot of first responders that come from a veteran background, military background. They may have military family. At the same time, we have people that continue to wear both hats, which is extremely impressive, reservists and such. So without further, welcome Dr. Thalia Nicholson and Dr. Larissa Tate.
Excellent. Excited to be here. Thanks so much for having us, Eric.
Yeah, absolutely. So I've been connected with Dr. Thalia for a little bit. We were bouncing around different ideas. I was really excited to be able to hear that you were connected with Dr. Larissa, a professional colleague on the East Coast. Thalia having a background specifically specializing in first responder side, but working with both sides. And then Dr. Larissa being the opposite. And so this is a really cool episode to bring together. What I'm excited about is getting a little deeper, beyond just talking about the stigmas and therapy and therapeutic options. And we're going to get into really how we can use these insights to get tangible takeaways and strategies to assist our people, but also the struggles and the hurdles logistically with fit for duty, with EAP, with clearance. And these things are obviously very jarring and scary for people when they try to consider how and in what manner they may reach out to share or ask for help. So with that, that's kind of the landscape we're talking about today. Dr. Thalia, can I start with you and just introduce yourself, say hello, and tell us a little bit about yourself and your background?
Of course. Hi, everybody. I'm Dr. Thalia Nicholson. I'm a clinical psychologist based in California. I'm licensed here in California and also in Nevada, and I specialize in working with first responders, active duty service members, and veterans, and just other frontline professionals like ER physicians, flight nurses, oncology nurses, you name it. And a lot of my work is on the clinical side, providing therapy to first responders and military personnel, as well as assessments. So, like you were saying, Eric, the fitness for duty, pre employment screenings, and what everybody loves to hear the special words, workers' compensation evaluations. And so a lot of the work I do, like I said, is first responder military focused, as well as giving trainings and consultation services to local departments here in California who are wanting to support their first responders in a more optimal way.
Yeah. Love it. Well, thank you for that introduction. We'll go to Dr. Larissa.
Sure. So I'm Dr. Larissa Tate. I'm also a clinical psychologist. I specialize in working with professionals in high stakes, high pressure roles. So people who are working in jobs that there's like very little room for error. A lot of times that is military. A lot of times it's people who've worked in those roles, like veterans. I also work with lawyers, other medical professionals, to include other therapists or psychologists. But basically, folks who are carrying a lot and really get their own space to slow down and take care of themselves. I also do individual therapy as well as group therapy and particularly work with sleep disorders. So people have trouble sleeping, as well as anxiety and trauma. And then I also do a lot of assessments too. So I differ a little bit than Dahlia does, but I do a lot of mental health evaluations, things like ADHD assessments, behavioral sleep medicine assessments. But I also do a lot of evaluations for the military. So people who are looking to join, enlist, or commission and need waivers perhaps for some past mental health difficulties they've struggled with or behavioral health concerns, or people who are looking to get back and to get cleared for fitness for duty.
Yeah. Well, fantastic. It's quite a buffet of resources and services you both provide. So we're just going to kick it off and talking about like therapy. And therapy is a very big word. I mean, it even goes into physical therapy. But for mental health clinicians, we talk about therapy, and we've had so many clinicians on the show, so many insights, and clearly, people, if they weren't personally familiar, they'll get a sense that there's all these different modalities and practices and personalities, and a lot of the things we talk about is, hey, don't write them all off. Don't write off like the whole concept of practice if you had a negative experience or your buddy or family member had a negative experience with quote unquote the broad brush of therapy. And so I kind of want to open it up there and talk about how both of you look at your clinical help and the services you provide when we think about something so broad like that.
I can jump back in. I think we're probably very aligned with this. But my main focus, you're right, there's lots of different types of therapies. Categorically, as a clinical psychologist, which means that we've trained in consumption and running of research, right? So we're very evidence based, very science background. So I particularly focus on the different therapies that we know are backed by science. We call them evidence based psychotherapies, or EBPs for short. What's great about these therapies, especially for first responder or military community, is that they work well. They have lots of evidence to show that they're very effective at treating a lot of the concerns that are very common in these kinds of populations. And they're also short term. So I think a lot of people think about therapy as in you got to be in it for years and years and years. I
Mm-hmm.
think that's very far from the case. Some people do, and sometimes that's beneficial for some people. Most people can get through what we call an episode of care. So, get through a therapy episode and get significant gains and reach their goals and go back to living their normal lives. I like to joke with my clients of like, ultimately, I want you to become your own therapist. I don't want you to need me
Mm,
anymore. I want you to get back to living the type of life that you want to be living without these things, whatever the concern is, whether it's trauma or sleep problems, whatever it is, without those things running your life. And a lot of times, not every time, but a lot of times, that's about 12 weeks of time that you're really doing once a week sessions, 3 to 4 months, and you're back to being able to manage those things without us. So I don't know if Thalia wants to add to that, but that's my general approach. And then there's specific types of therapies underneath that fall under that umbrella.
yeah, I love it. I love it how it's you can make the comparison to physical therapy, right? Like I know a lot of people that have been injured in and out of the job, a lot of first responders and just general civilians. And the goal and most of the actuality is not going to physical therapy for the rest of your life because you blew out a knee. It's you go intensely for a while and then you space it out and it becomes monthly, quarterly, and then you stop going unless there's a flare up, right? And you might have that checkup. And so I think that that is a really great thing to remind people of is like every situation is different, and there can be so much variability to that. So it doesn't have to be this like life changing thing that you have to build into your weekly or daily practice. Yeah, Thalia, what do you want to add there?
Yeah, I was just going to say the way I describe it is like we provide the first line gold standard medication, right? When you go to see your PCP, you want them to give you the medication that has been backed by research, has been around for a while. We know it's super effective for this condition, and that's what Larissa and I do is those evidence-based treatments that are highly researched and supported by VA and DoD clinical practice guidelines. And so, yeah, Larissa hit the nail on the head with their short term, 12 to 15 weeks. I mean, even for insomnia, it's shorter treatment than even the 12 weeks. And the nice thing for me is during my training years, my advanced training years, I was able to learn how to do models of accelerated service delivery. So it's taking our evidence based treatments and doing them in an accelerated fashion. That way we can meet the demands of the first responder culture, right? Like we sometimes don't have 3 to 4 months to do weekly sessions on the same day at the same time when we have rotating shifts and graveyard, et cetera. So I was able to train in this modality where we do this in an accelerated fashion. And a lot of times I get buy in because your symptoms are going to decrease a lot faster. You're not going to have to take as much leave from work, and your department's not going to be upset, right? So it's a win-win, and oftentimes a lot of people will just take the leave that they have at work, and they don't have to say anything to their department, right? Knock it out within 2 to 3 weeks, depending on how often we're seeing each other, and then you get to feeling better. And another thing that Larissa talked about, right, is like not needing us, right? Eventually, after we do the whole protocol or the episode of care, you go into what we call a maintenance phase. And that's really the opportunity to build that self efficacy for you to know how to implement the clinical tools without us checking in every single week, right?
Hmm.
And of course, life happens. Sometimes we have a little bump in symptoms, but you know what to implement now without needing a full course of care oftentimes.
Yeah, I like how you both hit on that, which is this is not a forever thing, and that's the goal, right? It's almost like teach a person to fish, and there's a physical trainer. You don't know how to work out per se, and you feel clunky around the gym, you feel awkward, and you have a trainer. Most people aren't out there selling this like, yeah, I'm like sign me on for a 5 year contract. It's like, no, like let's do this for a few weeks, let's do this for a few months, and then you see a lot of people like the good trainers set you up with that knowledge. Like you start internalizing this thing that works for you. You build confidence, just like you mentioned, and then you're off to the races. And you might have this maintenance thing because there's something specific you're working out because you have more of the background there. I want to talk about talk, and I'll kind of throw out two different perspectives that a lot of people throw out, which is, yeah, I have someone to talk to. Yeah, I don't need that. I talk to my significant other, or I talk to my pastor or my battle buddy, right? My peer support. So there's that, like, I do talk. And then there's the other aspect, which is like, okay, I don't want to just talk because that's not enough. So what am I going to do with a therapist that I don't know and just talk about my stuff? So I'm going to kind of open it up there and see who wants to chime in.
The number one factor in therapy that promotes change is actually the rapport you build with your clinician. So, the talking aspect and getting to know one another and building that rapport actually is wonderful. But the difference is with what Larissa and I do is that we're actually giving you clinical tools that you're going to be implementing in between sessions. So, kind of going on the physical fitness kind of journey you were describing, imagine going and seeing your physical trainer once a week for 1 hour. Are we really going to see the most change? Probably not. And hopefully, that doesn't ruffle feathers for other clinicians. But we're going to give you the tools so you can continue going to the gym by yourself and practicing these tools in your own environment. Again, building that sense of self confidence while decreasing your symptoms and concerns and getting you back to feeling your most optimal self. So it's it's definitely not talk therapy. Of course, it's supportive. We build that relationship, but we're here to give you the tools that are effective, right? It's kind of like going to your PCP. You're not just going to talk, they're going to give you the medication so you can get to feeling better.
Yeah.
I would just add We talk a little bit about this umbrella of EBPs, evidence-based psychotherapy, right? There's kind of this other umbrella where we would kind of categorize this as supportive psychotherapy. That's what most people mean by talk therapy when they're saying, I just want to have somebody to talk to. I want to talk about day to day stressors, right? It's helpful for me to just kind of bounce something off, which is it has the role and it can be really helpful for some people. When we're talking more about like clinical issues that are interfering with our functioning, that is where EBPs really shine. Um, you're coming in and yes, you're talking because that's how we communicate what's going on in our brains and our minds, right? We're not psychics, we're psychologists. So we can't read your mind. You got to tell us what's going on, right? So there's some talking there. But what's different is exactly what Thalia said is that we're giving you clinical skills, right? And I want to be mindful that this is above and beyond than what you can kind of research on your own, right? If you're coming to therapy, you're coming because something in your life is not working for you, right?
Hmm.
And you are looking for somebody to be able to give you expert advice and expert, let's call them tweaks and changes to make, both in session and that outside of session piece. That's really important. And so we are talking. We're talking about skills. We're talking about what's going to work best for you. And then you're also expected to do something different, right, in between sessions. And whether you can do that or not, right? That's not necessarily what we care about. There's barriers. We talk about that too, right? We try to find workarounds, but think of this as solution oriented, problem focused, time limited is kind of our short terms for what we're looking for. Um, so yeah, just adding that on.
Yeah, and I think that's really tangible for a lot of our, I'll say, our types, first responders, high performance, action oriented, military, like that. It's exactly that. Like we want to be doing something actionable, and so the talk, it sounds like a metaphor would be like that's the vehicle, right? But then all the tools, all the gadgets, all the stuff that's on board the vehicle, right? Those are the strategies, the evidence based techniques that you're getting with a clinician. Can you share some of those EBTs as examples of things that people might have heard about, or are there ones that you just find? And I know this could be very personalized, but ones that you find that you defer to, or are general entry points for a lot of people you work with.
Yeah. Larissa, maybe I can talk about the PTSD ones and you can take behavioral medicine. Awesome.
Go
So
team.
some of the most right, some of the most common ones for trauma that we implement are cognitive processing therapy, also known as CPT,
Hmm.
12 weeks long, and it targets the unhelpful beliefs that we develop following a traumatic incident. And Eric, I've heard you talk about this actually. I think 2 episodes ago of some of the thoughts that develop, like no one can be trusted. The world is completely dangerous. There's
Hmm.
something seriously wrong with me. I'm at fault for how that call went, or X, Y, and Z, right? So CPT targets these unhelpful beliefs and it builds by implementing clinical skills on how to create more adaptive ways of viewing ourselves, other people, in the world around us. So that's a gold standard treatment that we often implement at the VA. And then a second one is prolonged exposure therapy, also known as PE. I say on average it's 12 sessions. An early responder can be 8 sessions, and then it can go up to 15 sessions. And this is where you are decreasing avoidance, because avoidance is the number one factor that keeps us stuck in the recovery process from PTSD. And so our PTSD treatments are exposure based. Prolonged exposure has you doing imaginal exposures. And this is going to sound scary, but it's baby steps. But essentially, what you do is you recount in session what happened during the most traumatic event. And that's in an effort to allow your brain to make sense of what happened, start processing it, and decrease that avoidance, and show yourself that you can handle the emotions, that the memory itself is not dangerous to you anymore, and make meaning out of it. In addition to the imaginals and PE, you're also doing in vivo exposures, which is going out into the community essentially and doing things that you have avoided doing because it brings up that hypervigilance, that head on a swivel, needing to be like suss out the situation, find all your exits. And so it's going to a restaurant and not sitting with your back to the wall, or going to an amusement park with your family. And every time you build on these exposures, it builds up your confidence and shows that, you really are in relatively safe situations. And the reason your amygdala is firing in fight or flight is because of your job, right? This is what you're constantly seeing. So it makes you feel like you need to be on edge all the time. But in reality, civilians are skipping around town, seeing rainbows and butterflies while you're looking at what is the worst possible thing that can happen and how can I keep my family safe. Um, I'll pause there. There's a couple other evidence-based treatments, but those are typically the two gold standard go-tos.
Yeah. Before you even get into this, do you ever have to work through with patients just like the word choice? Because we say, like, hey, we're going to remove the stigma, and maybe someone's meeting with you in person or remotely, whatnot. But even the words like PTSD or trauma, like, I'm not affected by
Mhm.
trauma. But if we say stress, then people are like, oh my God, yeah, my stress through the roof. I can't sleep and I can't think about anything but work and I have trouble talking to people. Like, I feel like there's some things that people are very comfortable admitting and acknowledging, and there's some things that certain people are just very like opposed to.
1,000%. Yeah, you're hitting the nail on the head. You can typically tell when somebody, even the language that's being used, can elicit uncomfortability, right? And so it's meeting them where they're at rather than using this overly clinical terminology and language, and really trying to build that therapeutic rapport, build that insight for the client of like, hey, like let's see how this has impacted you. And a lot of people are like, oh my gosh, I did not even realize this. Even if wife or partner, whoever has been telling them, hey, you need to go get support. And a lot of times too, with first responder, as you have talked about in the podcast, is it often shows up as physiological. So a lot of the language that I use is talking about the physiology. What are you feeling? And one simple example is like this fear response, right? Like of freezing during calls. Okay, so you worry about freezing during a call now after what happened. Your body kind of shuts down. Or you notice that you're getting headaches now after being on shift, and that never happened before. Or you're struggling to make quick decisions on the job, and you're worried that people are noticing. And so, talking about that fatigue, definitely.
Yeah. Okay. No, that totally makes sense. And then the other thing, as far as exposure, I think those examples that you pointed out will really stick out to people. There are people that are like, yeah, I don't like sitting with my back to the door. And yeah, I don't like going to amusement parks. And so, what would help someone discern like the difference of how much of a potential, I'm trying to choose my words, right? Like a potential hurdle this is for their quality of life, as opposed to a certain level of, a certain level of discerning cynicism or, hypervigilance that they feel is responsible, get knowing what we know and seeing what we see.
Hmm. A lot of times I phrase the exposures as an opportunity to do the things that you used to do that now you can't and are impacting your day to day life with your family, with yourself, your ability to have self care, even as simple as going to the gym or the grocery store, right? And so these, what I call experiments, don't always have to be worst case scenario, the most uncomfortable situation. It could be things that you haven't done because of the impact the job that the cumulative trauma has had on you. And so it could be as simple as calling that friend and going fishing for an hour, right? That could be an exercise in itself. But of course, we build up because, like, when they are able to address the more lower level, not as much arousal exercises, it builds their self efficacy to be able to do harder and harder things on what we call their hierarchy. But it's not always things that remind us of what happened. It could also be self care activities that we have neglected because we haven't put ourselves first, because we may be putting our family first, we may be putting work first, and or living in the past, right? And so this allows you to practice being in the present moment and noticing that you are in a relatively safe situation and you can enjoy your company and your family and not be on edge and not be irritable or angry and ready to leave the situation.
Yeah, yeah, I like that. It makes me think of being curious about that, right? Like being open ended with yourself and introspective of like, okay, am I living the life I had always wanted to live, right? Am I living in such a way? Am I looking at the world in a way that I think serves me? Like, do I feel like I can do the things I want to do? Am I not doing those things, and why not? And then the things that come up, like, are they true or not, right? Like, well, I can't because blank. Well, is that actually true? Let's be curious. Let's ask some questions. Let's talk to our people. So, yeah, thanks for that, Thalia.
One of the things that I talk about if we make a PTSD diagnosis, we say, hey, these are the things that we're dealing with, and we just happen to call this cluster, this constellation of symptoms and discomforts you're experiencing PTSD. And I kind of explain these too as these these reactions that people are having, the feeling on edge, the changes in your mood, having trouble sleeping, right? These are all completely normal reactions to really abnormal experiences.
Mm-hmm.
That a lot of what your body is doing is trying to protect you from some sort of stressor. It's just right now that stressor might be over or it's not consistently ongoing. And so what these therapies are really helpful at doing is actually kind of think about it. We're not having you be on a light switch because some of these symptoms are really helpful, right? Like if you're going out for a walk in the middle of the night, we want you to be scanning, right? Or when
Mm-hmm.
you're at work, you're on call, we want you to be more aware and alert than you would be at home.
Right.
What these therapies are really helpful in doing is thinking about putting it not on a switch, but on a dimmer. We want you to be
Mm-hmm.
able to turn those things up when you need them and turn them down when we don't need them, depending on the setting. So I just kind of wanted to throw that out there.
Yeah, I like that. I think that that's really going to resonate with people. Kind of that image where, I mean, we talk about, the color scales of vigilance, right? So the whites, like
Exactly.
I'm just pure Zen. I think a lot of first responders and military folks probably can't really reconcile that, and like what it would take for you to get there. For me, it's like it's probably vacation a few days in, depending on where the vacation is, right? And
Mhm.
it's home now, but for a long time until I moved, until I worked on a lot of the stuff we're talking about, I didn't realize how hyper vigilant I was in my own house, like for years and years. And so until you remove yourself from that situation, and it doesn't mean move, guys. It just means like introspect, talk to people, and ask yourself why not. So no, that's really helpful in painting that.
Great, good. Would it be helpful to talk a little bit about some of these sleep stuff, or do we want to
Yeah,
save that?
people are always curious about sleep, and they always want sleep tips. And so I think that, I mean, already the obvious thing is there's a strong interplay, and we say it all the time, like all health is interrelated.
Sure.
But yeah, please.
The first thing I want to acknowledge is that oftentimes when people think about sleep problems, they don't really think about people like me, like psychologists, right, as being a pretty integral part of that care team. But we actually have a whole specialty called behavioral sleep medicine. And a lot of sleep difficulties that are especially common with the first responder military populations um, are things like insomnia, nightmares, right? Insomnia is where you're having difficulty falling asleep, staying asleep, you're waking up too early, sometimes all of the above.
Hmm.
Nightmares where you're having just recurring distressing dreams that are waking you up and it's happening multiple times a week or multiple times a month. Most people have like nightmares twice a year, right? But it's a lot more common in this particular population. And so we have some really good evidence-based therapies for that, for these things too. And what's really cool is they're actually even shorter than some of the other stuff we've been talking about. Usually like 6 to 8 sessions, we can get you back to sleeping how you want to. Um, so for insomnia, one of the gold standards that we do is something called cognitive behavioral therapy for insomnia, or CBTI. You
Hmm.
can think of this as basically like sleep retraining, right? It helps people retrain their sleep by changing unhelpful habits. So things that we're doing or not doing that might be impacting our sleep that we're not really even aware of. Helping us get back on a regular schedule that's actually going to allow us to have good quality sleep and refreshing sleep. And also addressing like that anxious thought pattern that we can fall into and lying awake and not being able to go to sleep by changing
Hmm.
kind of some of those things too. And so what's great about this is that instead of forcing sleep or relying on medication, we teach skills that help sleep happen more naturally and consistently over time. And there's no side effects that there are for medications other than we're going to mess around with your sleep a little bit till we get it to where you want it to be. So you might feel a little more tired initially as we're kind of tweaking some things. Um,
Yeah.
and then we also have cognitive behavioral therapy for nightmares or exposure relaxation restricting therapy for trauma related nightmares. So CBTN or ERRT, both of their operate very similarly. They're both evidence based treatments for nightmares. But these are really helpful if we're not really having a lot of those PTSD symptoms, but maybe nightmares are really bothersome. Um, this can be helpful by reducing the frequency and the intensity of the nightmares that we have so that we feel safer by going to sleep and or right less we call it physiologically aroused, right, where your body and your mind are just awake, right? Things like you have trouble falling asleep because you're checking the locks multiple times a night, right, or every time you wake up, you're having to do a lap around your house to make sure that it's all sealed, right? But that focus in CBTN or ERT is really on restoring that sense of control and calm around sleep, especially for people with kind of trauma-related nightmares, which we know we experience a lot in these populations. Um, and then the last little point I just wanted to mention, just based on what you were saying, Eric, about kind of reconnecting with values and this meaningful life is we have a therapy for that too, right? That is
Mm.
helpful for a broad spectrum of all sorts of things. It can be helpful with stress related symptoms. It can be helpful for anxiety or depression, or even if we're thinking about quitting smoking. We call it acceptance and commitment therapy, or ACT. And what's really great about this is it's focusing less on getting rid of uncomfortable thoughts or feelings, and more on improving your quality of life. And that's why it's really helpful for a number of different targets. And we're thinking about how do we change how we're responding to some of these very natural thoughts and feelings that come up for us. Um, and so instead of fighting with those, we work to help people respond with flexibility, with self compassion, with intention, so that these experiences, this internal dialogue, is no longer running the show, right? You're more in the control seat, or the driver's seat. And the goal is to really help people get back into alignment with what their values are, even when things feel harder. And I think that's especially helpful for a lot of first responders and military populations, because a lot of the things we do are also morally injurious, right? We have to do some things, or we see some things that are very much against our code of values and our ethics.
Hmm.
And so this can be a really helpful therapy to work through some of that too.
Yeah, yeah, that's huge. You said a lot. I kind of want to hit on a couple points. And one, um, so if it helps people quit smoking, can it help them quit Zen and dip and all those other dastardly habits that I fortunately don't partake in, but people at work just they
Yeah,
laugh at themselves. They're like, "Oh gosh, the taxes on this are ridiculous. I gotta quit this thing."
yeah, absolutely. It could be helpful for those things too, because it's all about, well, what do you want to change with your life, right? How are the things that you're
Hmm.
doing no longer aligned with what's important to you? And so maybe that's, using Zen, even though your spouse asked you to stop, right? Or,
Sinners
or
out
whatever
there,
it might be. Yeah.
beware. But there's hope. No, I love that. And when you're talking about sleep, and I've shared on here that I had probably all the sleep issues at different times, and something as simple, I say simple because it's not the level that you shared that, certainly people are grappling with daily. But something as simple as increased work stress on a certain day can throw me off for a couple days. It's just, I can see that interplay and that causation very clearly. But years ago, just grappling with actual insomnia and talking to my naturopath and all these things, but to wish that I had that knowledge and insight to utilize a psychologist and look at that angle of things for some of these strategies and practices. I certainly believe that would have been very helpful to process and contextualize and recognize some of these habits that might be not serving me, as far as what I'm priming my brain to do, right before bed, going to sleep, or like I would say, just crashing out because I was so exhausted. Some of these lifestyle things. So Are there things that either of you just want to throw out for people to think about?
Yeah, I think, yeah, first of all, sleep is so sensitive to stress, even like quote unquote good stress. It's not just quote unquote bad stress, right? So even just like starting a new job or getting into a new relationship, having a baby, of course, right, is going to impact your sleep.
Hmm.
So it's not just necessarily like the negative stress that can swing your sleep. But when you start to notice that you're having some sleep problems that are lasting like several weeks and it's happening multiple times a night, that's when we maybe want to think about getting connected with somebody like a psychologist who does behavioral sleep medicine work. But before you get to that point, you could do a couple of things, right? Is kind of run through a checklist of how you're kind of approaching your bedtime slash sleep in general, right? The first recommendation is making sure that your sleep environment's optimized for good sleep, right? We want to make sure your bedroom's cool. We want to like 65 degrees is generally a recommendation. We want to make sure that it's dark, it's quiet. Um, this is especially important if you're working night shifts, right? So thinking about
Hmm.
how you can make your bedroom during the day a cave, right, where you're not going to have any distractions as much as possible. Um, Screen time before bed is a huge sleep interferer.
That's the
So
one. Hmm.
that's the one. Doom scrolling at night,
Yeah.
laying in your bed, not so great. So powering down all of your screens, and switching to something like reading or, not a ton of light, at least an hour before bedtime can be really helpful. Even blue light exposure can interfere with sleep. So it's really helpful for you to kind of allow your brain to recognize that it's nighttime because it's going to interpret all of those screens as the sun, right?
Hmm.
That's not going to be helpful for sleeping. Um, Being mindful too of like your speaking of Zen, right? Like your nicotine use, your caffeine use, those are both stimulants. They're going
Hmm.
to wake you up. So we want to try to cut those out 4 to 6 hours before bedtime. And then your alcohol use too. A lot of times people use alcohol to fall asleep because it makes
Yeah.
them sleepy.
Hmm.
Um, it makes me sleepy too. But what happens is as it's metabolized or as it moves through your body is it actually breaks up your sleep. So your sleep is going to be much more disruptive and less restful if we have alcohol. And so it's better to avoid that and take a little bit longer to fall asleep. Um, the other kind of main things that I really recommend is making sure that you have a consistent at least wake time. Staying consistent with your wake time every day, no matter how well you slept the night before, including the weekends, is really, really important to good quality sleep. It's going to do two things. It's going to help your circadian rhythm realign, which is basically your internal biological clock, right? The thing that is going to help you wake up and help put you to sleep. Um, that's really important. And then it's also going to build up the pressure for you to fall asleep at night. So the longer that you stay awake, the stronger your need to sleep is. So we in line with that, want to keep a consistent wake time and also not nap because of that. Um, so those are kind of generally the recommendations on where I'd start if we're starting to have some trouble sleeping.
Yeah, thanks so much. And I know, I don't want to take too much time on sleep, but I know that that is one of the hard hitters that people just grapple with, especially in shift work. And I know because I've been there, you hear some of these things, and so for the night shift workers and graveyard workers, I might be like, oh, I got to keep the same schedule. Well, there are hacks for that, and some of the when you time meals, and that can help reset your circadian rhythm. So there's a lot of resources on that. But I want to go to Thalia and see if there's anything you'd add, kind of to close off the sleep piece, and then we're gonna get into some brass tacks and the truly scary thing about, hey, how do I share and how much do I share, because I'm wary of how this can affect my job and my assignment and all those things.
Yeah, I think the way Larissa described it is perfect. The only thing I would add is what you're saying, right? Especially for first responders with rotating shifts, working graveyard, traditional CBTI is just not going to work, right? It makes it really, really hard, especially for first responders where their shifts are constantly changing week to week or month to month. And so it takes a little bit of time to find the perfect, what we call sleep prescription. And that does involve taking naps, right? Like you can't serve your community if you're sleep deprived. You got to also take care of yourself. And so we try to find the most optimal times based on how busy your department or your station is to take those emergency naps. And they're a lot shorter than what we would see prior to treatment. So rather than taking an hour, 2 hour nap during lunch, like for firefighters, for example, after lunch, they usually have a nap. It's taking a 20-30 minute nap earlier in the day if they're not running calls. And if they need to take it later in the day because they know that they're at a busy station, they're going to be waking up throughout the night, then do it, right? Like it's not going to be like the most detrimental, but like Larissa was saying, is trying to find the most conducive schedule that you can stick to throughout the week. And then
Mm.
the other thing too is kind of with the scrolling thing, a lot of what we say with insomnia and treatment is the only thing that we use the bed for is sleeping and sexual activity. And so a lot of people will be like, oh, well, if I wake up throughout the middle, then I could just read a book to decompress. And we're like, no, no, no. Like if you're going to read a book, like you have to get physically out of bed, go sit somewhere where it's not going to like be your like relaxation zone. It's going to keep you awake and you don't fall asleep on the couch then. So we want to keep the same spot where we're sleeping and not be doing other things like working, looking at phone, reading, etc. in bed.
Are you looking for help with your rest and recovery, wanting to optimize your sleep and prime performance? Well, New Calm is built on neuroscience, and it's been used by special operators, SportTAC, pro sports teams, and many, many more for years. To learn more and access the best deals of the year, go to newcalm.co/grit. That's Newcalm, NUCALM.co/grit. You train for the threats you can see, but what about the ones you can't? United Diagnostic Services brings hospital-grade diagnostic technology directly to first responder agencies, making early detection of cardiovascular disease and cancer more accessible than ever. UDS provides comprehensive early detection programs using advanced ultrasound, CT calcium scoring, stress echoes, and innovative blood panels to identify potential health risks long before symptoms appear. It's proactive, on-site, and built specifically for those who serve. Early detection saves lives and careers. Learn more at udshealth.com. Yeah. No, that's a huge, great tip, and I think it's worth throwing that challenge flag. Not a sports fan, so my friends are gonna love that I just said that. But yeah, if you're reading something, unless it's like nursery rhymes and like just like Zen Buddhist like quotes that you can just read like one and then close your eyes and then like pass out, like I would say no, like that doesn't work. Like you gotta use your hands, you gotta manipulate your fingers, you gotta use your eyes, you need some sort of light source. And so no, I'm gonna throw the flag on that. So yeah, good. Thank you for sharing that. Let's go. We're gonna take a hard pivot, but I do want to get into this stuff because I don't know that we've talked about it very specifically on the show before, but it is on the front of a lot of people's minds, especially those in peer support, those running wellness programs. Those are trying to, beat the drum like, guys, if you need help, we're here, we're here. There's a lot of things we can do, a lot of resources we can connect you with. But there is that truly jarring, like, well, what if, right? What if, and we see it in our friends and colleagues and our partners across the country and beyond, that is a reality depending on what's going on. So can one of you kick that off?
Yeah. I love that you keep bringing up peer support. I've been working with CAL FIRE and learning more about their peer support program. And a quick thing I want to add is when you use your peer support program, depending on your department and the state you're in, ask them like what do you keep confidential versus what do you have to disclose, because it's different than a clinician. They have other regulations depending on the state that they're in, and they're used to answering that question. And I guess I'm making assumption, hopefully their state has rules around what they would have to disclose.
Hmm.
But in terms of confidentiality, the big word that people get worried about. I I lay it out from the beginning, right? Like, this is what everybody wants to know. So, like, let's jump in. There's 4 reasons I would have to break confidentiality, right? The first is if I am court ordered to. So, if I am subpoenaed, that does not warrant breaking confidentiality. I would ask you, do you feel comfortable with me releasing your records? If you say no, then I would assert privilege on your behalf and say, no, I'm not releasing my client's records. But if a judge court orders, of course, we have to. That's out of our control. Very uncommon in the line of work that Larissa and I do, but always like people to be aware of it. The second reason is if you disclose that you are wanting to cause serious harm to yourself. So I tell people, if you are cutting, if you are hurting yourself in any way that does not warrant breaking confidentiality, if you are having passive suicidal thoughts or thoughts, I wish I just didn't have to wake up, or I wish I could just be done with everything that's happening, that is a normal human experience. Most people have those thoughts at some point in their life. But if you tell me, hey, Thalia, on this day, at this time, with these means, and I have this intent to act on it, we would do safety planning. If I still felt like you're a risk to yourself, I would tell you in that moment, hey, I am worried about your safety. Let's collaboratively figure out better care or more intensive care so you can feel stabilized, right? For you to feel like you can engage with other people, to engage in therapy, to engage in your family in a safe way and not be a risk to yourself. And something that I specifically do with my first responders and active duty service members is creating a plan from the get go. If risk was to ever increase, even if you're telling me at intake, there is no suicidality, no homicidal ideation, none of that, I still am going to figure out if there was, what emergency department do you feel the most comfortable going to? Which is the one that you don't typically take patients to? Which is the one you don't have colleagues at? If I need to call the emergency department in our area, who do you want me to ask to speak to if I can get a hold of them? Who is a backup person? That way, we are decreasing some of that stigma that comes with suicidal ideation, intent, and plan, right? I want to have this plan in place so people actually know, okay, this is what it actually looks like when Thalia has to make sure that I'm not a risk to myself and it's not going to get to the entire department like quick fire. And then the other reason we would break confidentiality is if you have serious intent, means, and a plan to harm a specific person or entity of people, we would have to warn that individual as well as law enforcement, as you know, Eric. And then the last reason is mandated reporting, child, elderly, and dependent abuse. Those are really the 4 main reasons. Now, confidentiality looks different with workers' comp, pre-employment fitness for duty evaluations, and EAP. But that is if you are going and seeing a clinician for therapy. Those are the common reasons. Usually across all the states, those are the fixed ones.
Yeah, and I think that's something that's so, so helpful, and I hope people share this episode out or, this as a reference point because I've been in the job for, like, going on 20 years, and I've been in peer support, involved as a peer support member, for the majority of my career, and more recently being, like, a team lead, right? So, like, being surrounded in a lot of these conversations, but it was not for the majority of my career. For the majority of my career, I was not aware of the difference of suicidal thoughts, like passive suicidal thoughts, as you described, and active or imminent type of, yeah, I want to hurt myself right now. I have a plan. Like the difference between that, like, yeah, I'm gonna drive my car across this bridge. Like I'm in the, I don't know what else to do. This is my only choice kind of thing. And I just don't feel like living. Like I feel really sad. I feel really, I don't see the point. No, I don't have a plan. I just want to sit here and I just would prefer not to exist. And I think that that's very helpful for people to know there's a difference, not just as peer support, but as a colleague, but also as someone that might have any range of these thoughts and feelings, just to know what you're getting into. And the other piece I really want to hit on, and I love how I've been talking to a lot of different people on a lot of different topics on here, but we talk about leadership a lot, very clearly. We talk about building trust as police leaders, as bosses, but a lot of what you just said is just clear expectation setting to build trust. And that's where I really love how we enter this conversation and the ideas, which is like, look at your clinician like a partner, like a resource, like a teammate, like a coach. They're not going to do the work for you, but they're going to be there literally, figuratively beside you to help you along. Like, you have to do the work, but you don't have to do it alone. You're certainly not having to do it alone. So I really appreciate how you underlined a lot of those aspects there.
Yeah, I mean, I always want to be upfront because a lot of people, like you said, have heard of things going awry, right? And that is unfortunate, right? And would hope that most clinicians have a higher level of tolerance. But the thing is, even if the clinician says, I'm really worried about your safety, I think we need to get a higher level of care. When you go to be evaluated, if you're actually not a risk to yourself, they're gonna say, "Okay, you can go home. We're not gonna 5150 you," you know? Unfortunately, that's still a really crappy situation to go through, but most clinicians have a higher level of tolerance, right? And like you also said, do you have the means? Somebody can tell me, "Oh, I have a plan to jump off this bridge," right? And it's, like, all the way across the country, right? Like, the likelihood of them acting on it is a lot lower, and how are they going to be able to do that, right? So it takes a lot of, like, clinical decision making and assessing and also really having those frank conversations and feeling comfortable doing that with your client, and like you said, it's a partnership. I wanna make sure that you're safe to yourself so we could do the best work in here, and if you are feeling this low, in reality, we're probably not going to make the most progress. So let's get you feeling better, and then we can see how therapy is going to look moving forward.
Yeah. Yeah, you said there's a difference, so I want to revisit that. There's a difference with talking to your clinician, and then when you engage with these other branches of L&I, workers' comp, EAP type of scenarios. Can you get a little bit into that?
Yeah, of course. So I want to preface like this might be dependent state to state, but for the work that I do here in California, so everything I just discussed with confidentiality for therapy stays. Now, if you're doing workers' compensation, right, you come to see me for an evaluation, you filed a claim, you're needing treatment. Technically, the workers' comp representative, that department is my patient. So, what you disclose to me during the evaluation, I do report back in a thorough, comprehensive report, making a case as to why or why not you have an occupational injury, right? And why or why not you would benefit from treatment. So, things are disclosed to workers' comp. Now, workers' comp is focused on occupational injury. So if you are disclosing things about personal life that really have nothing to do with why we are sitting here today, those stay between us, right? But it's really that occupational factor. Similarly, with pre employment and fitness for duty evaluations, the department is my patient, quote unquote, right? The person
Yeah.
who's sitting
Mhm.
in front, a law enforcement officer, firefighter, they are not my patient. So, what they disclose during their pre employment or fitness for duty evaluation does get reported back to the department. Again, it's focused though on readiness to engage in the job or readiness to return back to the job after a critical incident or whatever has happened to warrant a fitness for duty evaluation. Now, with EAP is a little different. So, EAP is therapy, right? Um, Depending on the EAP program, and your clinician should tell you this from the beginning, most EAPs, at least in my region, you are not having to put a diagnosis on record. Most of the time, it's called like a problem area, right? Anger, family concerns, trauma. And that's how you bill rather than putting those diagnoses, those labels that you were saying earlier, Eric, the PTSD, the depression, the generalized anxiety disorder, whatever it is, EAP typically doesn't need that level. But again, your clinician should be telling you based on your department's EAP program. Those things that you are disclosing are staying between you and EAP, and that is strictly for reimbursement. It doesn't go to your captain, it doesn't go to your chief, doesn't go to anybody in your department, it's just between you and your clinician. Now, if your captain or chief or somebody higher up your command says, I am requiring you to go get treatment, and oftentimes it'll be used through EAP. Your clinician will disclose whether or not you are attending. They are not going to disclose the content of your sessions. But again, there's that confidentiality nuance there of like, I do have to tell them, yes, they are attending, and that's that. I know that was a lot of information there and differences between all the entities, but happy to answer any additional questions.
Yeah, no, I think that's really helpful, just to help break that down. And people, I encourage you to listen to it back. But I think that that can also help in clarification for a lot of the stereotypes or stigmas of, oh yeah, EAP sucks, it doesn't work, and like that also is going to be highly individualized by area, region, department, like clinician, right? The actual administration of your employer, like whatever government you work for, like they're going to have a different program. And so I think you did a great job underlying a lot of the things which go from like state law, a lot of these definitions, the clear expectations of the provider, and then who the provider, who the clinician is kind of working for in what context. So, and I know we could go on and on a lot of different ways in that. So if listeners want that type of follow up, like please like shoot me a message and we can definitely dial it up. Um, I do want to go over to Dr. Larissa and kind of talk about or open it up per se. If there's anything you want to contribute from your perspective in a lot of things we just talked about, maybe for veterans as well. But I also want to be mindful of both your time.
Sure. I think Dahlia did a really nice job of just very over arching themes and really explaining what we mean by different things. I think the only thing I would add is it can operate fairly similar, like within active duty populations, right? Like especially if you're getting a fitness for duty eval or you're, whether that's outside or inside of your branch, right? That the person who is doing that evaluation, the clinician, is in one way doing wearing dual hats, right? Even if you're paying for your own assessment, they are also kind of addressing the referral question from whatever branch that you're thinking about, right? So it's really important that they're answering what is needed, but we are mindful about, like, we don't have to tell them everything as far as your personal details. We're answering just what the question is, right? Which for me a lot of the times is this past history of a behavioral health problem interfering with their ability to do their job, right? Um, are they fit to enlist in the military given this? There are some diagnoses in the past that are, there's not really waivers for that are just automatically excluded, but most aren't, right? So I think that's just an important caveat, and the person that you're doing this evaluation with should be talking to you about this as well, right? They should be going over confidentiality explicitly in the type of appointment that you're having, right? Whether it's therapy, whether it's an evaluation, whether it's whatever else, peer support, right? People should be
Yeah.
talking about what this means. Um, and then when it comes to like veteran stuff, right? Like I don't do too many evals, but if you're going to do like CNP exams or things like that, they should be going over confidentiality with you, right? And I would argue, like, a lot of the times the clinician opposite of you, they're on your side. They're human, right? And so being as open as you can with folks is hard, especially meeting a stranger for the first time, but that's what's gonna serve you best, right? We're not trying to be gatekeepers with these kinds of evaluations, right? We're trying to make sure that we're ethically, responsibly helping you with whatever your goals might be, um, while maintaining that objective presence. So, and that also kind of goes back to tie it back to that the talk about suicidal thoughts and things like that. The more open that you can be with whoever you're working with, the better that we can help you, right? And I tell my patients or my clients a lot that, if something changes, if they're denying any suicidal thoughts, right? If something changes, you got to keep me in the loop because the sooner you let me know, the sooner that we can make some plans to keep you out of the hospital, right? To make sure that you stay safe. So it doesn't automatically mean you say I had this thought one time last week, right? Doesn't mean that we're going to send you to the hospital, right? What it does is say, oh, we need to look out for that. We need to make a plan that also might be like what Thalia mentioned earlier as a safety plan, which is how do we keep you safe, right? Who do we connect you with? What kinds of things can we do to keep you out of that downward spiral. Um, and it can also mean like we change our treatment plan, right? If we were focusing on sleep and then suddenly these thoughts were coming back up, maybe we need to focus on these thoughts for a little bit, right? And get a hold of them before we try to tackle something else.
Yeah, I think the last piece, just bouncing off what you just said too, is like it's okay to try and to find out that it's not the right fit for you, right? Like
Yeah.
a clinic might not be the right fit, an evidence-based treatment might not be the right fit. And it's just like on the medical or physical side of things. One treatment may not always fit everybody. It's impossible. So like that's where like the patience and understanding comes in because you do deserve to feel better. You do deserve to find the right fit with a clinician and to feel heard and to be met where you're at and to get the treatment that's going to be the most effective and conducive for who you are and your occupation and your background and all the stuff. So thank you for having us on here. If anybody has additional questions or wants to reach out, you can find me at americasfirstresponder services.com or on Instagram, America's First Responder Services. Pretty straightforward.
Fantastic. Thank you, Thalia. And Larissa, we'll close it out with you.
Thanks. I echo everything Thalia said. I think that's a really, really brilliant way to sum it up. Give it a try, right? And again, going back to that openness, if you're feeling like it's not a good fit, I want to know, right? Like as your clinician, I want to know. I'm not going to be offended. There's things that I can make changes. I'm going to make them. If I can't, I'll connect you to somebody who's a better fit, right? As we mentioned before, like a lot of what therapy is about the rapport too, right? You can give all the great scientific backed tools, right, which is a really, really important part, and you got to have somebody that you trust and that you're working with in order to actually do that. So be open and give it a try. Um, I'm also happy to answer any questions. If anybody is interested in reaching out to me, my website is momentumbehavioralhealth.com. You can also reach me on Instagram at dr.larissa.tate. I meant to mention before, if you're interested in working with me, I'm licensed in New York, North Carolina, Maryland, Alabama, and Florida,
Oh my gosh.
collecting them all.
Yeah, that's legit. Dr. Thalia, did you mention where you're licensed?
Yeah, I think at the beginning, California and Nevada and
Okay,
to see.
great. Good reminder. Well, thank you both so much. And for listeners, the info will be in the show notes. So if you're driving, don't start typing that into your Instagram app right now. Please be safe, and thank you all for joining today.
Thank you.
Thank you for tuning into another episode of Blue Grit Radio. As always, support this community by subscribing, giving us a 5-star review, and following, liking, and sharing posts on Blue Grit Wellness on Instagram. You can reach me there or email me at bluegritwellness@gmail.com. Be well and stay gritty.